In this episode, we'll be discussing alpha adrenergic receptor antagonists, also known as alpha blockers. Alpha blockers generally work by altering the sympathetic nervous system, primarily via the alpha-1 adrenergic receptor subfamily. These receptors are widely distributed and can be found in tissues of the heart, central nervous system, blood vessels, and of course, the GU system. The binding of noradrenaline to alpha receptors leads to contraction at the bladder neck, proximal urethra, and the prostate. Inversely, blockade of these receptors leads to relaxation of smooth muscle, decrease of sympathetic baseline muscle tone, and relief of symptoms. When we look at the distribution of alpha-1 subtypes, we see that the 1A subtype is most predominantly found, shown here in blue. There's also the presence of B and D subtypes, which are much less predominant. There are a number of side effects to be aware of with alpha blockers, based on their involvement in blood vessels and the central nervous system. These include orthostatic hypotension, reflex tachycardia, ejaculatory dysfunction, intraoperative floppy iris syndrome, dizziness, weakness or asthenia, rhinitis, meiosis, and sedation. Ejaculatory dysfunction with alpha blockers is often believed to be due to retrograde ejaculation, similar to what we see after a TURP is performed. However, studies have shown that selective alpha blockers, while they decrease semen volume, they don't increase post-ejaculate urine sperm concentrations. Therefore, the true mechanism for ejaculatory dysfunction is likely that alpha blockers paralyze smooth muscles of the prostate and ejaculatory ducts, leading to anejaculation, as opposed to retrograde. When we discuss intraoperative floppy iris syndrome, we should characterize it as a triad of progressive intraoperative meiosis, billowing of a flaccid iris, and iris prolapse towards the incision site during cataract surgery. Tamsulosin has been shown to carry the highest risk, but all alpha blockers increase the risk of IFIS to some degree. Discontinuation of tamsulosin about 4 to 7 days prior to cataract surgery is routine, and urologists initiating alpha blockers should inquire about the presence of cataracts or plans for future cataract surgery and inform of the risks. Alpha blockers are broadly classified as non-selective, meaning those that involve alpha-1 and alpha-2 subtypes, selective or uroselective, which have the most selectivity, preferring alpha-1A and alpha-1D subtypes over alpha-1B. Phenoxybenzamine is a non-selective alpha-1 blocker that works by irreversible covalent blockade of alpha-1 and alpha-2 receptors. Because of this mechanism, side effects can persist until new receptors can be synthesized. Side effects include orthostatic hypotension and reflex tachycardia, and the primary indication for this medication is pre-op catecholamine blockade and pheochromocytoma. Patients are started on 10 mg BID about 7 to 14 days prior to surgery, and are titrated to a blood pressure of 120 to 130 over 80 millimeters per mercury while seated. Terazacin, doxazacin, or prazosin can be used as alternatives in pre-op catecholamine blockade, as these are often better tolerated, easier to find, and much cheaper. Terazacin is a selective alpha-1 blocker that is approved for both LUTS BPH and hypertension. Side effects include postural hypotension, dizziness, and weakness. Patients must be titrated to minimize the risk of first-dose hypotension and syncope, and are usually started with 1 mg at bedtime, but can go up to 5 or 10 mg. These patients are at significant risk of hypotension when this is combined with PDE5 inhibitors. Doxazacin is also a selective alpha-1 blocker approved for the use in LUTS BPH and hypertension. Side effects also include postural hypotension, dizziness, and weakness, and the initial dose is 4 mg after breakfast, eventually increased to 8 mg. These patients are also at significant risk of hypotension with PDE5 inhibitors. Tamsulosin is a uroselective alpha blocker with affinity for the alpha-1A subtype at 10 to 1 compared to the alpha 1b subtype. It's approved for LUTS BPH and has side effects of rhinitis and ejaculatory dysfunction. The initial dose is 0.4 milligrams taken after the same meal each day up to 0.8 milligrams, and it's shown to have the highest risk of IFIS with 40 times that of alfuzacin. Silodosin is a uroselective alpha blocker with affinity for the alpha 1a subtype at 161 to 1 when compared to the alpha 1b subtype. It's approved for LUTS BPH, and the initial dose is 8 milligrams with the same meal each day. Side effects include rhinitis and ejaculatory dysfunction that is the worst of all alpha blockers. Alfuzacin is a uroselective blocker with highly selective blockade of alpha 1. It's approved for LUTS BPH with an initial dose of 10 milligrams with the same meal each day. Of note, it has minimal ejaculatory dysfunction and is appropriate for patients who prioritize this. The role of alpha blockers in medical expulsive therapy is based on the fact that ureter contractility is mediated by alpha receptors in the ureteral wall. Alpha blockers potentially reduce ureteral spasm and uncontrolled contractions, leading to decreased pain and promoting of spontaneous stone passage. The AUA guidelines recommends alpha blockers in uncomplicated distal stones less than or equal to 10 millimeters. It should be noted that no benefit was observed for stones less than 5 millimeters, likely because these stones are already small with a high spontaneous passage rate. We hope you enjoyed the episode. Thanks for watching.